Good evening, respected professor and my dear students. I welcome you all to our fourth session of rapid fire discussion. Today's topic will be covering drugs, equipments, and related things for our practical exam. Over to professor and students. Thank you.
Thank you. I think I will first go with the drugs because I think as recently as the end of December, we discussed machines and vaporizers in two classes. So I will try to cover the drugs and equipments today. Okay. So I'll start go with my presentation or the PPTs on drugs in anesthesia. Is the screen visible for you?
Yes, sir.
Okay. So the drugs commonly kept in your practical exams can be classified into the intravenous induction agents, the muscle relaxants, the analgesics, the inhalational agents, and the reversal agents, and some of the critical care drugs like antiarrhythmics and other IV fluids. All these things come under the drugs classification. And there are two methods of questioning in the examination. And where the examiner can ask you to pick up any drug which will be spread on the table and ask you to describe that. Or they may select one drug and give it to you and ask pertinent questions on that particular drug. So these are the two common methods of the examiners dealing with the drugs in the examination. So if they give you the drug or if you select a drug and if they just ask you to describe that, first you must identify under which category it comes, whether it is a intravenous induction agent or whether it is a muscle relaxant or it is an analgesic. Then you must tell the chemical nature of the drug, which group or which class of chemical it belongs to, like imidazole or a benzofuran or a cyclophenanthrine group. Like that, you must tell the chemical name. Then you must tell the presentations, how it is marketed, whether it is a liquid or a lyophilized powder. Then the next thing is you must say the salient features of the drug, what is it used for, and what then will be the dose of the drug. For various drugs may have different doses. For induction, you may have one dose. For maintenance, you may have another dose. For low dose nowadays, we have another very small dose being given. So you must describe the dose of the drug. Then you must tell the advantages and disadvantages or the adverse effects of that and route of administration, whether it is given IV, IM, subcutaneous, intranasal, intrathecal, or intrarectal. So all these methods you have to go one by one and describe. On the contrary, if the examiner straight away asks you, for example, they give you a bottle of choline and then ask you what is this, then you may say this is a muscle relaxant, depolarizing type of muscle relaxant called succinylcholine is the chemical name for that. And they may ask you what are all the adverse effects of this drug or the complications of using this drug. Then you can start saying from the myalgia produced by the vasculations, hyperkalemia, go to the extreme of malignant hyperthermia at the last, and like that you can describe about the individual complications of the drug. So with this brief introduction, I will start with the first intravenous induction agents, and of that thiopentol sodium, which was one of the commonly used induction agent about 15-20 years ago. But after the advent of propofol, this has almost become obsolete, but still being used in some centers or in some particular conditions. And so this is a very popular drug, repeatedly asked in the examination, because students may not be commonly using this drug. So you must know what are all the points that you have to know. What is this thiopentol sodium? What is thiopentol sodium? That is the first question that you may have to answer. Can you answer that question? What is thiopentol sodium? I think by mistake I clicked the answer also there.
sulfur analog of oxybarbiturates.
Yes, it's a sulfur analog of oxybarbiturate pentobarbital. How is barbituric acid formed?
Sir, by the combination of urea and melanic acid.
Melanic acid, very good. So urea and melanic acid produce barbituric acid in water. How is it marketed and what is the reason for it being marketed in that particular form? Is it a powder or a liquid?
Anhydrous powder, sir.
It is an anhydrous powder. And how is it marketed? What is there in the vial above the powder? Is
It
it a
has
vacuum
nitrogen
or
in
it
the
is
place
air?
of air.
Pardon?
Nitrogen in the place of air, sir.
Nitrogen in the place of, so it is not a vacuum, it is nitrogen filled in the vial above the powder. Why nitrogen is there instead of air?
Sir, it has the property of tautomerism. If it combines with air, it forms a carbonic acid and it will lead to acidic pH, sir. So in order to prevent the reaction and the acidic pH, nitrous is there in the place of air.
Okay. So it is marketed in two forms. One is 500 milligram and vials. Both of them are powder only. You have to reconstitute that. But one form which is given as a 500 milligram, how much of saline you can put? Can you put saline in that to dissolve this?
Yes, sir. 20 ml of saline, which is acidic pH, it will form a precipitate.
That is the catch in the question. If you say, if the examiner says, can you put saline, you should say no, because it will not dissolve in saline. Okay, you have to put only pure water, distilled water, and dissolve that. It will not dissolve properly in saline. And you have, if you put 20 ml, it will become how many milligrams per ml? This
25
vial,
milligram.
it will become 2.5% or 25 milligram per ml. Okay.
Yes, sir.
On the contrary, if it is 1 gram vial, how much you should put?
40 ml.
How much? 40 ml you have to put. Why 2.5? Why dilution to 25 milligram is better than just putting 10 ml and making it 50 milligrams?
Since it is very alkaline at high concentration, it will lead to
Yes, if there is
irritation.
an externalization, it will burn the tissues and destroy them. Okay, so it is always dilute it as much as possible. What is the dose of this drug for induction of anesthesia?
It is 4 to 5 milligram per
3
kg.
to 5, 3 to 5 milligram. Okay, so it is easier to give the correct dose by diluting it to 25 milligram per ml or 2.5% rather 5% solution. Okay, these are the common questions they may ask you. So for 500 milligram vial, better to dilute it with 20 ml of distilled water. For 1 gram vial, better to dilute it with 40 ml of distilled water so that you will get 25 milligram per ml, which is 2.5% of solution, which is safer because you can give 3 to 5 milligram per kg body weight. So it is a yellow powder which has a sodium carbonate, disodium carbonate in nitrogen atmosphere. Okay, what is the purpose of this disodium carbonate?
Sir, upon dilution, it will make it more alkaline.
Alkaline, yes. Bicarbonate, with that it will make it strong alkaline solution. What is the pH? You are saying alkaline, alkaline. What is the pH after you reconstitute it with water? It is between 10.4 to 11. Okay, very highly alkaline solution, and that is the reason why it is marketed as a powder, because once you reconstitute it, alkaline solutions will not stay stable in the room temperature for more than 24 hours. If you refrigerate it at 4 degrees centigrade, you can use it up to 1 week. 3 to 7 days you can use. But if it is kept open in the room atmospheric temperature, the potency will be lost. So that is the reason why all drugs which have a acidic pH on reconstitution, alkaline pH on reconstitution, will be marketed as a powder for immediate reconstitution and use. And the reason for the nitrogen is already I said, carbon dioxide in air will react with water to form bicarbonate and hydrogen ion and cause less alkalinity, will make it less water soluble. So that is the reason why it is filled with nitrogen. And does it exhibit tautomerism?
Yes, sir.
What is tautomerism?
So the drug can have two pHs both. It can become water soluble and also lipid soluble.
Different pHs, it
pH.
behaves in a different manner. That is what is called tautomerism. Okay. When it is in the bottle, it is very highly alkaline. But when it goes into our body, it becomes our body pH is between 7.35 to 7.45. So it is much less. So in that thing, the structure will change and it will become water soluble instead of being non-water soluble when it is in the powder form. Okay, so that is called the tautomerism. So it is water soluble enol form and less water soluble keto form. There are two chemical names you have to remember. One is called the water soluble enol form and less water soluble keto form, which can change with the dilution. What is its effect on respiration? When you use it as an induction agent and start giving this drug, in those days, we used to observe closely how the patient's respiration changes and try to adjust the dose accordingly or stop giving the drug further by looking at a particular response in the patient's respiration. What is that called? Nowadays, you will have less chances of observing that because mostly you are using only propofol. So the answer for that is it is causes what is called a double apnea in respiration. Can you make a guess what is this double apnea?
First it will cause deep, then it will go to shallow.
First it will cause deep, then it go to shallow.
Shallow.
Okay. You say apnea. Now, what do you mean by first it will go to deep? It is rather the other way. See, as you start injecting the drug, what will happen? Initially, patient will breathe with the normal tidal volume. Then slowly the tidal volume will go on decreasing, that you will see as though patient is not breathing, but the tidal volume may reduce to as much as 40 to 50 ml, but still there is some respiration. Okay. But when you look at the chest wall, you cannot make out any inspiratory or expiratory effort because the tidal volume has reduced to such a slow level. Then what happens? Patient will take a deep inspiration and become totally apneic. This is what is called as a double apnea. So initial apnea is because of the reduced tidal volume where you are visually not able to appreciate any respiratory movement. But after a deep inspiration, patient will become totally apneic when there will be no airflow at all. That is called the double apnea. So the initial apnea lasts for a few seconds, followed by a few breaths of normal breathing. Initially, it will be a normal tidal volume breathing. Then people have measured the tidal volume in the very, very shallow breathing, which is almost 40 to 50 ml total. And again followed by a prolonged apnea after a deep inspiration, which may necessitate respiratory assistance by jaw holding and bag and mask ventilation during induction with barbiturates. Okay, this is a very classical response that you will see. Okay, so these are the questions which are commonly asked, and there is also another important question: what is the absolute contraindication for usage of tapentone? And what other drugs have to be avoided while using? Porphyria is an excellent answer. That is the correct answer for absolute contraindication, which can produce an acute porphyric crisis. What will be the symptoms of porphyric crisis if somebody has mistakenly given this drug for patients with porphyria? What are all the things that can happen?
Photosensitivity rash.
Photosensitivity. Okay. So other drugs you have to avoid are barbiturates, etomidate, halothane, lignocaine, bupivacaine, clonidine. All these things, patients who are in with porphyria, you have to avoid all these drugs also. Okay. So it is actually a problem. Where exactly is the porphyria? What is the pathophysiology?
Heme blocks the heme synthesis.
Heme production. Here is an enzyme called porphyrinogen. All of you would have studied that. So that will be the causing. It will cause a lot of neurological problems. Okay, it will extend the neurological crisis, and patient may go into deep coma. That is the problem with this particular congenital anomaly, but this is quite rare. So With all that, now thiopentone usage is also not there. So just for exam sake, you have to remember all these points. Now the next common agent that is used in every day is propofol. What is the chemical name of propofol?
Diisopropyl phenol.
2,6-diisopropyl. 2,6-diisophenol. Propyl phenol is the name of the drug. What preparations are available?
Lipid emulsions.
Lipid ml. How many vials? 10 ml, 20 ml, 30 ml, 50 ml.
20 ml and 50 ml vials.
Also
10
100
ml
ml are
also.
available. Okay. So you have three preparations. One is 20 ml vial or ampule, which will contain 1%, 20 milligram, 10 milligram per ml, or it may be 50 ml vials, or it may be 100 ml vials. Okay. So three preparations are there. What is the pKa and what is the advantage of it?
pKa is around 11.
Almost 7 point, entirely ionized at 11, and it is entirely ionized at 7.4, so it can enter cell membranes easily. It is the advantage. Okay. So drugs which are unionized, what do you mean by unionized?
Without any
Electrical
charge.
charge.
Yes.
Okay, so they can only penetrate and enter. Once they become charged, they cannot enter. So this drug remains unionized entirely at this pH, and so it is able to penetrate. What is why it is marketed as an emulsion? Why can't it be also be marketed as a powder? Because it is not water soluble. Okay, to make it water soluble, you have to make it into an emulsion, soybean oil and purified egg lecithin. So the composition also the examiners may ask you, apart from propofol, what are all the other ingredients there in the oil. The two important things you have to remember is soybean oil and purified egg lecithin. What is the importance of this egg lecithin?
So it can cause allergy.
Allergy. So people, you must always ask whether you have any egg allergy problem in the patient if you use propofol, so that you can find out and avoid the drug. What is propofol infusion syndrome and who are at the risk of this particular complication?
So propofol infusion syndrome is when we give propofol more than 4 milligram per kg per hour for more than 24 hours.
Okay,
It will
good.
lead to metabolic acidosis, hypertriglyceridemia, and rhabdomyolysis.
Excellent. Which group of patients are at this risk, adult or pediatric?
Pediatric.
Pediatric patients are more risk. So common presenting features are onset of metabolic acidosis, cardiac dysfunction, rhabdomyolysis, renal failure, and high triglyceridemia. Okay. So risk factors developing for propofol infusion syndrome are severe head injuries, sepsis, high exogenous endogenous catecholamine levels, glucocorticoid levels, low carbohydrate level, and inborn errors of fatty acid oxidation, and also pediatric age group. Okay. Now, what is shown here? It's one of the newer drugs which are likely to come into the market soon.
Phosphopropyl.
Propofol.
It's not phosphopropyl. You can see the name here. Ciprofol is different from phosphopropyl. Phosphopropyl is already there. This is a propofol analog with improved pharmacokinetic properties. Okay. How does it differ structurally from propofol? You said the propofol is 2,6-diisopropyl phenol. Does the compound vary or the constituent vary in the ciprofol? Okay, I think you have no idea about it. So ciprofol is 1-cyclopropylene ethyl 6-isopropyl phenol. Instead of 2,6-isopropyl phenol, it is with the second position there is also cyclopropyl ethyl component, and the incorporation of R chiral center and cyclopropyl group, improves the pharmacological and physicochemical properties, most notably being the potency of the more potent. The drug becomes more potent as well as eliciting less pain on injection. So if you see the structure, this is the propofol structure where you have 2,6-diisopropyl phenol only. Whereas here you can see there is a R-chiral center and also a cyclopropyl ethyl component attached to that. So this is the ciprofol. What are the safety features of ciprofol compared to propofol? Okay, the answer is the dose is much less compared to your propofol. What is the dose of propofol you give?
1 to 2 milligram per
1
kg.
to 2 milligram per kg. Whereas here it is starting dose is 0.15 to 0.90 milligram. Less than 1 milligram it will be enough. And ciprofol doses of 0.4 to 0.9 exhibit similar onset time, but at the same time 4 to 5 times more potency than propofol. Okay. And the other advantages, less pain on injection, less bradycardia and less hypotension compared to propofol, and that is the reason why this is being improved and waiting for getting the FDA has already approved, but still not commercially introduced into the market. Okay, that is a newer drug which you have to remember. Next is a very common drug. Mention the chemical properties of this drug.
Pencyclidine derivative.
Pencyclidine.
It is cyclohexanone pencyclidine. Okay, the pencyclidine, if you say it's enough, but if you do want to get better marks, you can also add it's a cyclohexanone derivative of pencyclidine, and it is a water soluble compound and presented in concentration of 10, 50 and 100 milligram per ml. And it is without preservative. It's also available with a pH of 3.5 to 5.5, and it's a race-mix mixture of 2 enantiomers. Okay, we saw in the last class in one of the ASCIIs what is a race-mix mixture, and I hope all of you remember that. What is the mechanism of action? How does it produce so much good analgesia?
Sir, it acts at NMDA receptor, NMDA antagonist. Also, it acts on the mu receptor and the sodium channels. So it produces analgesia.
It is an NMDA receptor antagonist. Very good. And NMDA receptor, L-glutamate receptors in the CNS are excitatory action. So ketamine binds to the cation channel in the receptor to block this effect. What cation is prevented from entering into this receptor?
Sodium.
Calcium. See, sodium is also one, but calcium is the binding one. Okay. So ketamine also acts on the opiate receptor by partial antagonism at mu, but agonist at kappa and delta receptors. Okay. The analgesia is produced by the agonist action at the kappa receptor. Mu is supposed to be the most potent analgesic, but it has slight antagonism there. But it has an agonistic action at the kappa and delta receptors to produce the analgesic action. What are the uses of ketamine in anesthesia? Where all you can use it?
It is used as an induction agent, sir.
Very good.
At
Can be used as both induction for adults and children. Excellent. Then
subanesthetic dose used as an analgesic agent, sir.
Subanesthetic used also can be used in field anesthesia, especially when there is a mass casualty and you go there to retrieve the injured patients. You can give ketamine intramuscularly also to retrieve them without pain, and can be used as a bronchodilator in refractory asthma. Okay? And that's one of the medical effects. And used with the treatment of chronic pain and for post analgesia, especially in patients who are opioid addicts, and used as pseudo analgesia during local or regional anesthesia. And what are the routes of administration of ketamine?
Sir, intravenous route, intramuscular, epidurals, intranasal.
Intrathecal also can be given.
Intranasal.
Ketamine also has
Yes,
been
sir.
demonstrated without preservative. Okay, so
Yes, sir.
IV, IM, oral, nasal, intrathecal, and epidural. Only except rectal, all the other routes, and transdermal also has not been given. So except those two routes, all the other routes are available. So what is the clinical sign of onset of action after ketamine in children?
Nis-
What effect you will see in the eyes?
Nystagmus.
Nystagmus, horizontal nystagmus is the effect that you will see. How much is the low dose ketamine and what is its use?
0.2 to 0.5 mg IV per kg, sir.
Less than 1.1 to 0.2. 0.5 is almost anesthetic dose. Okay,
Yes.
low dose is only 100 mics to 200 mics per kg used for short duration pain relief. Okay, so there you can use it for short periods like if you want to avoid too high a block in cesarean section and you want to give a block only up to T10 in risky case, you can give this low dose ketamine for the fundal pressure pain or discomfort that the mother experiences, or at the end of surgery when last few sutures are there and patient is complaining of pain after recovery from a spinal, you can use this as a short duration pain relief. Okay?
Yes, sir.
Next is the etomidate. Many of you would have had a chance, or some maybe would not have had a chance because this drug is not a very commonly used drug. So, what is the chemical nature of this drug?
Imidazole derivatives.
It is an imidazole derivative. Very good. How does etomidate affect the steroid synthesis?
Inhibits enzyme 17 alpha and 11 beta hydroxylase in the
Very
pathway.
good. Binds to 3450 enzyme 11 beta hydroxylase, which is important for stereogenesis. And this effect is due to binding of nitrogen atom in intermediate imidazole ring to the iron within the heme ring of the 11 beta hydroxylase enzyme, resulting in the inhibition of steroid formation. Okay, so this is how the packing or marketing comes as 10 ml vials containing 20 milligram, which is 2 milligram per ml. So what is the percentage?
It is 2%. If it is 20 milli,
2 milligram per
0.2%.
0.2 milligram. Okay, so 0.2%. What other imidazole derivative drugs are used?
midazolam.
Midazolam, then
Imidazole.
any other drug? Metronidazole, antifungal agents, and midazolam. These two are the other imidazole. What is the induction dose of etomidate?
So 0.3 to 0.8 mg per
0.3
kg.
milligram per kg. Okay. How is it metabolized in the body?
So by non-specific esterases in the body.
This is by hepatic esterases, non-specific hepatic esterases and plasma cholinesterases hydrolyze etomidate to ethyl alcohol and carboxylic acid metabolite. Okay. What are the unwanted side effects of this drug?
Sir, nausea, vomiting, myoclonus.
Pharmacology சொல்லி கொடுத்த மாதிரியா எல்லாத்துக்கும் ஒரு nausea, vomiting, diarrhea, pain on injection, excitatory movements, porphyric crisis also can be precipitated by this drug also, and nausea, vomiting. Okay, right. So these are the common induction agents. I have not included midazolam or benzodiazepam there. So now we go to the analgesics. And what is the difference between an opioid and an opioid?
Sir, opiate is naturally occurring. Opioid is a derivative of.
Derivative of that. Very good. So it's a synthetic substance is called opioid, and the naturally occurring substances are called opiate. So morphine is the example of an opiate, which is a naturally occurring substance, and all other drugs which have properties similar to the opiate or opioid. Okay. Describe the opioid receptors. How many types of opioid receptors are there, and what type of receptors are there?
4 types of
Rho,
receptors.
kappa, lambda.
Kappa, del, and NOP, orphan and NQs.
Okay. So what type of receptors are there? Sodium, ligand gated channel receptors or
G protein coupled
G
receptor
protein.
negative.
They are mostly G protein coupled receptors located through CNS, core of nucleus tractus solitarius, periaqueductal gray area, cerebral cortex, and thalamus. Okay, and they are located in spinal cord, GA tract, and peripheral afferent nerve terminals also. These are the locations. And there are mainly three types: mu, kappa, and delta. And of course, now the recent one is nociceptive receptor also. Why they were named mu, kappa, and delta? Any idea? They were named
Yes, sir.
using the first letter of the first ligand which bound to them. During the discovery, scientists found that some ligands or the chemicals were able to bind to these receptors. So based on the ligand which bound to them, they named it as mu, kappa, and delta. So what ligand or what chemical bound to mu? Morphine. So that is why it's called mo. What bound to the kappa?
Ketocyclosis.
Ketocyclosin. Very good. And delta?
So it is derived from mouse vas
Mass
deferens.
deferens. Okay, they found the receptors more in the vas deferens of the rats. Okay, so that is why it is called delta. Deferens became delta. Okay, it is not like the usual alpha, beta, gamma, delta, which are all Greek alphabets, but here it is because of the ligand that it was named. So how do opioids work?
So
What is their mechanism of action?
they have an inhibitory G protein coupled receptor action, and also
Yeah.
it blocks the calcium channel release and increases the intracellular potassium,
Cost?
causes decrease in the neurotransmitter release.
Hyperpolarization. Okay, so the activity is situated in the presynaptic area by closing the voltage gated sensitive calcium channels, stimulation of potassium efflux leading to hyperpolarization of the cell membrane. That is, when the inside of the cell becomes too much negative, it is called hyperpolarization. Okay, reduce the cyclic AMP production also, which reduces neuronal excitability. So these are the two mechanisms by which these receptors work. What is opioid-induced hyperalgesia?
So at low doses, they'll cause central sensitization leading to hyperalgesia.
Patients who are chronically exposed to opioid, they suddenly feel even a very long, innocuous, mild nociceptive stimulus causing extreme pain. Okay, so opioid induced is a state of nociceptive sensitization caused by exposure to too much of opioids. So it's a very paradoxical situation. Patient gets a lot of opioids, but suddenly they start feeling severe pain even with a very mild nociceptive stimulus. That is because there's a sensitization of the nociceptive receptors. Okay, that is what is causing this problem. So it's a paradoxical response whereby patient receiving opioids for the treatment of pain may actually become more sensitive to certain painful stimuli. Okay, that is called the, it's one of the common questions. So these are all the common questions before we start with the opioid. Now coming to the individual drugs, morphine. What is the chemical nature of morphine?
Derivative.
Cyclophenanthrin derivative. What are the preparations of morphine available?
Oral tablets.
Tablets are available, yes. Injectable morphine is available.
Injectable.
So you can get injectable, you can get tablets, sulfate. Any other salt of morphine is available? Get morphine sulfate here. Any other salt of morphine? Morphine suppositories are also there. Okay?
Yes, sir.
So morphine may cause muscle rigidity and meiosis. These are the two problems that morphine can produce and how they are produced. How does it cause muscle?
They interact with the dopamine at substantia nigra and
So it is by dopamine and GABA pathways, not substantia nigra location. So whereas the pathways are dopamine and GABA pathways. So interaction with these two pathways will cause muscle rigidity, and meiosis is due to stimulation of Edinger-Westphal nucleus. Okay, that pinpoint pupil which happens in morphine toxicity or overdosage is because of the stimulation of Edinger-Westphal nucleus. And morphine be used in renal failure?
No, sir. The
Why?
metabolic hydroxymorphine.
Morphine 6 glucuronide is a metabolic.
It is equally potent substance. Okay, metabolite of morphine, morphine 6 glucuronide, is more potent, accumulates in renal failure due to decreased excretion. Hence, it is not safe. What is the oral dose of morphine?
10
Usually
milligram.
given for palliative care in cancer patients.
5 to 10 milligrams.
5 to 20 milligram 4th hourly. Okay, so that much high dose can be given for palliative care patients with intractable cancer pain. What is the parenteral dose?
0.1 milligram per kg.
0.1 to 0.2 milligram. Very good. What is the intrathecal dose and what preparation to be used?
So maximum 100 mics, 0.1 milligram morphine without preservative.
Intrathecal dose is 1 to 3 milligram without preservative. Okay, preservative free morphine dose of 1 to 3 milligram is that is not based on body weight. It's a rough use of 1 to 3 milligram. What are the features of morphine overdose?
So they have decreased respiratory rate and increased tidal volume. They can have meiosis. They can have pruritus, urinary retention, constipation.
Excellent. So shallow breathing, complete cessation of breathing also can happen. Persistent sedation, unresponsive to painful stimuli, milder treatment, vivid dreams, hallucination, delirium, muscle twitching, drop in blood pressure, pinpoint pupils, slow erratic pulse, bluish or purple discoloration of the skin, and vomiting. Okay, these are all the various effects of morphine. Then comes the commonly used drug fentanyl. What is fentanyl chemically? Every day you are using in your
Piperidine derivatives.
it is a synthetic phenyl piperidine derivative. Okay, very good. What the salt of fentanyl used? What is the other chemical?
Something.
Every day you are using that, you are seeing the ampules. Fentanyl citrate. Okay, that is the salt. Fentanyl citrate is the. What are the routes of administration?
So transdermal, intravenous, intrathecal, epidural.
So commonly used routes are IV, intrathecal, transdermal, oral lozenges also are available. And you can use it in the, but it is not used that commonly in epidural like intrathecal. Because intrathecal we use it for a little prolongation of the subarachnoid block. But epidural we use a longer acting opioid rather than fentanyl. Okay? Transdermal is very commonly used, and nowadays we have oral lozenges also coming up in the market. So this is durogesic controlled drug release patches which can be put on the transdermal, releasing 50 micrograms per hour. And what is wooden chest syndrome? And why does it happen?
It also reacts with dopamine causing chest wall rigidity.
Same point like muscle rigidity in the last slide. So wooden chest syndrome is a chest wall rigidity during administration of fentanyl causing difficulty in ventilation. When will it happen? Does it happen? You are using it day in and day out. Does it happen in all your patients?
So when given fast and at a higher dose.
When it is given very rapidly, then only it will happen. So chest wall muscle rigidity is the result of fentanyl bound to mu opioid receptor in the central nervous system and activation of dopaminergic and GABA pathway as seen in that, but usually happens when this drug is administered very rapidly. How do you manage this?
So by giving 100% oxygen, positive pressure ventilation.
Assisted ventilation, yes. It's by antagonist. You can also give naloxone if it is not getting relief, or by giving a neuromuscular blocking agent like rocuronium, or cessation of fentanyl infusion with supportive care. What dose of fentanyl for opioid-based anesthesia? Supposing you want to do a cardiac case, you want to do it as a opioid-based anesthesia. Normally, you give how many micrograms per kg body weight?
Normally 1 to 2 mics per kg
1 to 2 you
IVs.
give, very good. But if it is opioid-based, what is the
5
dose?
to 10 mics per kg IV.
50 to 100 mics per kg. Very, very heavy dose. Okay, and this is the dose at which you may get this wooden chest syndrome. Okay, especially if you give it very fast. So, it is a very high dose that is given by mainly cardiac anesthesists, not the regular people. So, why intrathecal fentanyl does not cause respiratory depression like morphine?
So it
It
is
is a
highly
Lipophilic, sir.
Hmm.
So it stays there in the
Doesn't get
spreads.
shifted up. Okay, due to high lipid solubility, fentanyl rapidly enters the spinal cord from CSF and does not travel high up, whereas morphine does not dissolve or get that much of high lipid solubility. So with the CSF eddy current, it will gradually move up and go to a higher level and sometimes go into the intracranial compartment also. So delayed respiratory depression is very common with morphine. That is why whenever you give intrathecal morphine, patient needs to be observed for at least 24 to 72 hours for delayed respiratory depression. Whereas with fentanyl, this is not at all a common issue. Now comes the next drug, commonly used drug, tramadol. What is tramadol?
Cyclohexanol derivative
It's
opioids.
a cyclohexanol derivative. It is also a racemic mixture. How is it presented?
Colorless solution, 50 milligram per ml, 2 ml ampules.
Presented as either oral tablets or parenteral injection for IM or IV use. What is its mechanism of action?
It is a mu agonist.
Partial.
It's a very weak opioid agonist. Okay, agonist at all opioid receptors, especially mu receptor. It also called calm down on the locus coeruleus, so inhibiting the norepinephrine release. So two mechanisms of action: agonist at all opioid, but weak agonist. It's not a very strong agonist. And also it causes, there is a location called locus coeruleus in the brain, where it inhibits the norepinephrine release, which is important for conduction of nociceptive stimulus. What are the interactions of this drug? Important interactions.
So central
Serotonin sees
Can
tricyclic
interact with
antidepressants.
tricyclic antidepressants, SSRIs, and cause seizures. Okay, so because of this particular action, you have to be very watchful while doing this because they also act in the same manner. So it may cause severe inhibition and suddenly cause a release phenomena where it can cause seizures. And patients who are already having known epileptic patients, you have to avoid this because it reduces the seizure threshold also. What are the contraindications for its use? Not to be
Seizures.
used in patients suffering from epilepsy. How does tramadol help in controlling postspinal shivering? It's one of the common drugs used for preventing postspinal shivering. Which receptor activity causes this? So prevent shivering by inhibiting the reuptake of norepinephrine and serotonin and activating the descending inhibitory spinal pathways. Okay? So these are the mechanisms by which it controls the spinal shivering. What is a racemic mixture and give other examples?
The equal mixture of two enantiomers.
Enantiomer, dextro and levo. Other examples:
Ketamine, sir.
ketamine, bupivacaine. Okay, equal mixture of two enantiomers, dextro and levo respiratory optical isomers. Examples: bupivacaine and ketamine. Okay. Then remifentanil. This is a drug which has now become recently available in our market for the last 2 years. Are you people are using it in your hospital?
No, sir.
Yes, sir.
But because it's available and many hospitals have started using, I thought you should be aware of this. What is remifentanil?
So
It is also a
it's a synthetic
phenylpiperidine
phenyl
derivative.
It is a pure mu opioid agonist, receptor agonist. And what presentations are available?
Crystalline white powder.
Hmm. So
1
it is
mg
available in so many strengths. It is available as 1 milligram per vial, 5 milligram per vial, and 2 milligram per vial. These are the three strengths which is available. Describe the structure activity relationship of remifentanil.
It has a carboxyl ester group in.
Carboxyl ester group. Okay. It is very much like the parent drug fentanyl, but addition of an ester group highlighted by arrow and pointed repeatedly metabolized by non-specific esterases. So this is the structure of fentanyl, and to that there is an ester group added here. Okay, that is what the difference between that. So this makes this drug to be metabolized by non-specific plasma and tissue esterases. So this gives its characteristic ultra-fast offset and allows for rapid titration. That is the advantage of this particular structure. Can remifentanil be used in patients with choline apnea and in renal failure?
Mm,
Yes, sir.
yes, sir.
Because it is metabolized by plasma hydrolysis.
So it is non-specific plasma esterases. So it is not the specific butyl and choline esterases which is this choline being metabolized. In renal failure, what happens? Despite known broken down by esterases, remifentanil used in pseudocholinesterase deficiency also. Okay, so there is no connection with the pseudocholinesterase which metabolizes as choline. So it can be used in patients with history of or family history of choline apnea. But in renal failure, what can happen? Can it be used or not? What is the metabolic product of remifentanil after they are metabolized by these plasma esterases?
a carboxylic acid metabolite, sorry, which is inactive.
Carbolic acid. It is called remifentanil acid. Okay, carboxylic is also called remifentanil acid. But this remifentanil acid has no effect at all. It's not at all an active compound. Just like when you say morphine 6-glucuronide is equally potent like morphine, the remifentanil metabolite remifentanilic acid is not having any action of parent compound remifentanil. So even though it accumulates and it is excreted by renal mechanism, it will not cause any depression. So it can be safely used in that also. What are the effects on the cardiovascular and respiratory system when remifentanil is used?
Similar to other opioids, it can also cause respiratory depression.
Depression, serious
Decreasing
hypotension,
the
bradycardia,
BP and
as well as
heart rate.
apnea are all these common effects. What should be the rescue when should the rescue analgesia be administered before discontinuing remifentanil infusion? Because the moment you discontinue, within few minutes, patient will start feeling the pain. So as long as the infusion is on, patient will be comfortable. So you should administer some rescue analgesia before thinking of discontinuing intraoperative fentanyl. So what are
10
the
minutes before.
30 minutes? Okay, should be given at least 30 minutes before stopping infusion to reach the peak effect of the drug that you give, so that the patient will not have pain post-operatively. And some more questions on that is, what is the body weight Why? Which body weight is considered for dosing of remifentanil?
Total body weight, sir.
You sure?
Yeah.
It is the lean body weight. The plasma pharmacokinetics are remifentanil closely associated with lean body weight rather than the actual body weight or total body weight. Okay. Which is a common mode of model TCA used for administration of remifentanil and why?
Minto.
Elivel.
Minto model. Somebody else I heard. Correct. You are right. Minto model TCA, named after its developer, Dr. Charles Minto, is a model for predicting the concentration of remifentanil in plasma and its effect site. While more accurate models are available, this model, because of its versatility and wider body of experience, have led to being used as the most widely used model. Okay. What is the dose of GA and what is the context sensitive half-life of remifentanil? When you give the
kg IV, sir.
Hmm.
Context sensitive half-life based on the duration of.
So
3
this
to
is
10
0.1 to 0.3 microgram per kg per minute. Okay, that is the dose for intraoperative supplementation during general anesthesia. And context sensitivity half time,
In 1 hour, it is 4 minutes, sir.
it is 3 to 4 minutes, not 1 hour. It's about only 3 to 4 minutes. That's why I told you, as soon as you stop that, if you have not given rescue analgesia, patient will complain of severe pain. So the short half-life is very, very short. That is the reason why it has to be supplemented with a rescue analgesia well in advance. What are the uses of remifentanil? Where all it can be used? Apart
labor
from
analgesia.
very good general anesthesia, intubation without muscle relaxant, remifentanil patient controlled analgesia for labor, awake fiber optic intubation, conscious sedation, and analgesia and sedation for management of patients in ICU. Okay, all these are the uses of remifentanil. How is remifentanil infusion prepared? Earlier I showed you that there are 3 preparations, 1 milligram, 2 milligram, and 5 milligram. So 2 milligram dissolved in 40 ml of normal saline will yield 50 microgram per ml, or 1 milligram dissolved in 20 ml will also give 50 microgram. 5 milligram dissolved in 50 ml will give 100 microgram. Okay, so depending upon that, you can titrate it and give. Next drug is pentazocine. I don't know how many of you are still using it. Some hospitals continue to use it. So comes under the common trade name Fortin by Ranbaxy and company. What is pentazocine?
So it is a partial antagonist at mu and agonist at kappa
It
delta.
is an agonist antagonist. One word answer. It is an agonist antagonist. It's a synthetic analgesic benzomorphone derivative. Both agonist and weak antagonist activity at the opioid receptor. You can just remember it is an agonist antagonist. Any other drug with the same character of agonist antagonist?
Buprenorphine.
Buprenorphine, fantastic. That is also a similar drug. And also other group like this. There are a big number used in different hospitals. How does it produce analgesia? Which receptor activation? Agonist.
Receptors.
It is more a kappa receptor rather than mu receptor. Okay, so that is why the potency is not as good as morphine. Any drug acting on the mu receptor will have the best analgesia. Next best only will be kappa receptor. Okay, so can it be used for pain relief in acute MI?
No, sir.
Why?
Receptor antagonist.
Which receptor?
Potent analgesia acts only on mu receptors.
Okay, but this kappa receptor analgesia is there. No? Supposing you don't get morphine and you have only morphine, can it be used or not? Tomorrow you go and join a hospital, patient comes with a classical anginal pain. There is no morphine in that hospital, but morphine is available. Will you give that or not? You should not give, because in patients with acute myocardial infarction, it produces substantial elevation in cardiac preload and afterload, and also increases the cardiac workload. Okay. In addition, it increases systemic and pulmonary artery pressure, left ventricular filling pressure, and systemic vascular resistance, and decreases left ventricular ejection fraction. Okay. So because of this reason, this is not the ideal drug for myocardial infarction pain. What is ceiling effect of a drug? Most of the opioids, this question may be asked in the exam. What is the ceiling effect of a drug?
Sir, once the receptors are saturated, even after giving higher doses, it will not produce analgesia.
So increasing the dose does not increase the analgesia or the respiratory depression. This phenomena is a drug reaches maximum effect, so that increasing the dosage does not increase in its effectiveness. That is called the ceiling effect. We have reached the saturated point. We have achieved the maximum analgesia. For example, 14 comes at a dose of 30 milligram. Supposing up to 60 milligram, you will have very good analgesia. But increasing it beyond 60 milligram to 90 or 120 does not improve the analgesia. Okay, so only up to a particular dosage it will have the maximum effect. Beyond that, increasing the dose does not increase the effectiveness. That is called the ceiling effect. What are the adverse effects of pentazocine?
Hallucinations.
Common sweating, sedation, dizziness, nausea. What is the dose of pentazocine?
25 to 30 milligram direct IM, or
so it is 0.5 to 1 milligram per kg IM or IV, or oral 550 milligram QI. Okay, it is available also as a tablet, so you can give that one also. Now this is another drug which you are using commonly. What category of drug this belongs to, and what are its actions?
Alpha 2 agonist, sir.
Alpha 2 agonist, very good. What are its actions?
It can be used as a sedative. Its infusion can be used for sedation in the ICU, or it can be used as an analgesia or an additive for intrathecal or epidural or nerve.
Very good. Causes anxiolysis, sedation, analgesia, and anti-shivering property. Very good drug to prevent shivering, especially before spinal or in the theater where the ambient temperature is very low. This prevents shivering. What are its uses and dosage?
conscious sedation. For
Preoperative
conscious sedation,
application is anxiolysis. Intraoperative you can use for rigid bronchoscopy and magnetic resonance imaging cases you can use, and it can be used for sleep studies where sedative properties are parallel to natural sleep. You can use it for neurosurgical procedures like posterior spinal fusion, and facilities for intraoperative wake-up tests during spinal cord surgery. When you want to do wake-up test, this will be a good drug to reduce the inhalation agents and relaxants and do the wake-up test. And combining it with ketamine is a good sedation analgesia for burns, dressing, and it reduces the emergence delirium or agitation, and reduces the opioid requirement, and also reduces the oxygen desaturation in obstructive sleep apnea, and prevents post-operative shivering. What about the dosage? This drug is given at the dose of 0.5 to 1 microgram bolus, followed by infusion of 0.2 to 0.7 microgram per kg per hour, titrated as desired sedation. Okay. What are the adverse effects and how they are explained?
sir, it causes initial tachycardia, then hypotension and bradycardia.
Conjunctional rhythm, sir.
Does not cause any hypertension. It causes
Initial
hypo and
hypertension.
brady first, then hypertension. Okay. So
Yes, sir.
common effects are hypotension, bradycardia, followed by hypertension. So how do you explain that? Why does it cause hypertension and bradycardia initially and then hypertension?
So it also blocks peripheral alpha receptors
Alpha
leading to
receptors, that is the reason
vasodilation.
for the hypertension. But bradycardia is a result of stimulation of presynaptic alpha receptors, which lead to decreased release of norepinephrine, added with the central sympathetic outflow depression. Okay, these are the two mechanisms by which the initial hypotension and bradycardia will happen. But later on, hypertension results from stimulation of alpha subtypes of receptors in vascular smooth muscles. So, how to avoid the hypertension, which will happen after some time when you start the drug?
We can avoid the loading dose.
Very good. You can avoid loading dose or you can administer the drug very slowly. These are the two mechanisms by which you can avoid the hypertensive response. Now comes the NSAIDs, which are also used for analgesia in our common practice. The first and foremost drug, all of you should be very, very familiar with this drug being used every day in your practice, paracetamol. Okay, this is the infusion that you have. What is the composition of paracetamol infusion that you are using?
Paracetamol with methionine.
Paracetamol. Is it only paracetamol or some other things are also there in that
Water.
bottle? Do you have only paracetamol and water or something else? None of you have seen the label or gone through the composition.
Mannitol.
Each ml contains 1000 milligram or 1 gram of paracetamol. Other ingredients are cysteine hydrochloride monohydrate, disodium phosphate dihydrate, hydrochloric acid, and sodium hydroxide, mannitol, and water for injections. All these things are there in the infusion. How are prostaglandins synthesized?
They are derived from arachidonic acid.
Arachidonic acid. By what enzyme?
Cyclooxygenase.
Cyclooxygenase. You must tell the enzymes also. Okay. Membrane phospholipase have cytosolic phospholipase, which is this is the first enzyme to convert the membrane phospholipid into arachidonic acid. Okay. Cytosolic phospholipase A2. Then arachidonic acid is acted upon by cyclooxygenase 1 and 2 enzyme, which produces prostaglandin PGU2, and PGH synthetase goes back, and from that you have all these varieties of isomerases, synthesis, and etc. Finally, leading to so many varieties of prostaglandins and also thromboxane A2. This much of end products are produced. So, can paracetamol be called NSAID?
No, sir.
Why?
It has
It
got
does
only
not cause,
central
it doesn't have
It
anti-inflammatory.
doesn't have anti-inflammatory effect. It has only analgesic effect. Though it is usually classified under this category, it is strictly speaking not an NSAID at all. Okay, it is because it has very little anti-inflammatory activity. It treats pain mainly by blocking cyclooxygenase, mostly in the central nervous system, but not much in the rest of the body. Okay, what happens in paracetamol overdose?
Hepatotoxicity, sir.
Pardon?
Hepatotoxicity, sir.
Hepatotoxicity, how is it produced? Why it happens?
It causes necrosis of the hepatocyte.
Para-amino
Benzoic acid.
which saturates the enzyme and the conjugation of glutathione, leading to hepatotoxicity.
Acute liver failure due to formation of a compound called NAPQI, which is toxic to hepatocytes. Okay. So this is the acetaminophen is your paracetamol. Normally it is metabolized by two routes: conjugation with glucuronic acid, which produces a non-toxic substance. Similarly, conjugation with the sulfate moiety, that also produces a non-toxic component. Once these routes of elimination are overwhelmed by excess dose of acetaminophen, then it is activated by P450 enzyme, which produces this toxic compound called N-acetyl P-benzophenonimine. That is the short form NAPQI. QI, which is toxic. Okay, and this toxic product can be made non-toxic by adding glutathione, which will be improved by giving N-acetylcysteine. So one of the common treatment that we have to give for paracetamol overdoses is administration of N-acetylcysteine within how many hours?
In 4 hours.
4 to 6 hours. Yes, before the maximum dose gets absorbed, you must give it so that there will be glutathione availability will be made more, and this toxic compound also will be made into non-toxic cysteine and methactopuric acid, and the liver failure can be prevented. Okay, so this is one of the common questions that you have to be aware of, and that is why too much of paracetamol infusion in liver failure patients should not be done. What is the maximum dose you can give per day?
Normally it is 4 gram. In patient with the liver failure, it is 2 to 3 grams.
So reduce the dose. Okay, that is the reason why that question is asked. What are the side effects of NSAID and how are they caused?
So they cause gastritis, renal insufficiency, bronchospasm in patients with known asthmatics.
Asthma. Very good. So the main side effects are renal failure, aggravation of gastric ulcer, bleeding, and aggravation of asthma. Okay, these are the 4 important side effects. How does the renal failure occur?
So it blocks the synthesis of prostaglandin I2, which is a vasodilator.
Which
So
part of the kidney?
with COX, with
Capillary
cyclops.
necrosis.
Huh?
Medulla is affected, sir.
Medulla, yeah, because medulla already has a lower blood supply. 20% of the total blood flow goes to medulla, whereas the 80% of renal blood flow goes to cortex. So, and that for the maintenance of medullary blood flow is mainly by the prostaglandin. And if that is blocked, that blood flow also will be reduced, and medullary ischemia and interstitial nephritis. These are the 2 changes that will happen in the kidney, which will cause the main reason for renal failure. And why gastric ulcer gets aggravated?
So prostaglandin is protective for mucosal layer.
It is important for synthesis of the mucus layer covering. Okay, the mucus production will be inhibited, so that the exposure of the gastric ulcers to the acid secretion will be more, and gastric acid ulcer aggravation will happen. Why bleeding happens?
Some of them have antiplatelet action.
Platelet also will be present. That is the reason why. And why asthma gets worsened?
So because it inhibits the cyclooxygenase pathway, all will diverted to lipooxygenase pathway.
Unopposed action of leukotrienes, which is produced by lipooxygenase. Okay, that is the reason. So blocking of prostaglandin results in renal damage by causing renal inner medullary ischemia and interstitial nephritis. In the stomach, mucus production is blocked by the same mechanism, resulting in exposure of the acid to the stomach, leading to ulceration. Blockade of thromboxane leads to bleeding, and an unopposed leukotrienes caused by aggravation of asthma. Okay. What are the routes of administration of diclofenac?
Intramuscular, intravenous, perrectal, transdermal.
Transdermal. Okay. Excellent. So diclofenac is another drug which you are all must be very familiar using it every day. So these are the 75 milligram per ml ampules are available, and suppositories for pediatric use available as 12.5 and 25 milligrams. And surface diclofenac OLE gel, all of you know that being advertised in the lay public, also in the common media. What is the chemical class of diclofenac? This is coming under a classical NSAID. The chemical class belongs to phenyl acetic acids. It is one of the phenyl acetic acids. What is the dose of diclofenac?
So it's 1 milligram per kg IV or IM, a total dose of 150 milligram per day.
Per day. Okay. 100 to 150 milligram per day can be given as a oral, and intravenous It is about 7.5 milligram bolus injection every 6 hours. Okay, but in
Yes.
the OT, normally we dilute 75 milligram and administer it as a bolus for long surgeries. So even giving 75 milligram over a period of for half an hour to 1 hour does not cause any problem. Okay. How are NSAIDs classified? There are classification of these drugs.
So non-specific COX inhibitor and selective COX-2 inhibitor.
Active, very good. So it is a classification by Tripathi where it can be non-selective COX inhibitor, preferential COX-2 inhibitor, and selective COX-2 inhibitor, and analgesic and antipyretic with poor anti-inflammatory action. So your paracetamol, Nifopam, all these things come under this category. Even though it is grouped under NSAID, they are strictly not NSAIDs. Whereas the first category, which is a non-selective COX inhibitor, common drug is aspirin, which we use every day. Then indomethacin, which is another drug which is used very commonly. And all these oxyphenobutazone, phenylbutazone, ketoprofen, ibuprofen, naproxen, all these things are more given as oral preparations rather than parenteral preparation and not commonly used in our anesthetic practice. Whereas diclofenac is a common drug which we are using day in and out. It is a preferential COX-2 inhibitor. And selective COX-2 inhibitor is celecoxib, Vitoroxib, and paracoxib. These have been almost banned now because of some unwanted cardiovascular effects. So commonly used drug is only a preferential COX-2 inhibitor. Why COX-2 enzymes are specifically inhibited? When you have both cyclooxygenase 1 and 2, we normally use drugs which inhibit only cyclooxygenase 2. Why?
So they are the inducible enzymes.
Excellent, fantastic. These are the, so COX-1 enzyme is a constitutive nature. That is, it is secreted without induction of injury, and that is called the housekeeper enzyme. Whereas COX-2 will be induced only when there is a trauma or injury, like your surgical injury or when you are major trauma. So whereas COX-2 is induced following injury. Can you give any other example of enzyme induced like this in our body?
So interleukins 1/6, tumor necrosis factor
An
alpha
anti-inflammatory cytokine.
enzyme.
There are variety of, it is also called inducible that dash dash. Just like inducible COX-2, nitric oxide. Okay.
Yes.
So nitric oxide is a similar, inducible nitric oxide is there, neuronal nitric oxide is there, vascular endothelial nitric oxide is there, plus inducible nitric oxide is also there. Okay. So these are the analgesic drugs, opioids and non-opioids, which we commonly use. Now we go on to the local anesthetic drugs. How are local anesthetic drugs classified?
Sir, ester compounds and amide.
Ester and amide, why is taking so much time? Very easy. Ester group or ester linked and amide linked. Okay. And of course, under that category, you have long, short, intermediate acting and all this classification. But mainly ester linked or amide linked. That is the answer that you have to give. How is lidocaine or lidocaine metabolized in our body?
Sir, it is metabolized in the liver
Liver, right?
to xylidide compounds.
Very good. So metabolic pathway is oxidative to the liver. Monoethyl glycine xylidide. That is the metabolic product. Monoethyl glycine xylidide, followed by hydrolysis to xylidide. Ultimately, it ends up as xylidide, and it has 80% activity of lidocaine and a prolonged elimination half-life. The hepatic disease decreases in hepatic blood flow will cause a decrease in the metabolism. So patients with liver failure or patients with poor hepatic blood flow, we have to be careful in giving the lignocaine. How does prilocaine cause methemoglobinemia?
Sir, it inhibits the enzyme methionase.
So it's metabolized to orthotoluidine. Prilocaine is metabolized to orthotoluidine. Orthotoluidine is the one which causes methemoglobinemia. Okay, and then now dose needed for that is more than 600 milligram, and this may be present in which may look cause some amount of cyanotic look and decrease the oxygen carrying capacity also. So the metabolic product orthotoluidine is the culprit for producing methemoglobinemia. What is methemoglobinemia? What is the normal forms of iron that we have?
Ferrous to
The
ferric,
ferrous
sir.
getting converted to ferric. Fe2 becoming Fe3. The difference between lignocaine and mepivacaine.
So,
Mepivacaine
mepivacaine
has
is
a okay. Tell me, mepivacaine is
a short-acting local anesthetic metabolized by esterases.
esterases. So it's a similar to lidocaine, although duration of action is somewhat longer, not short acting. Okay.
Yes.
In contrast to lidocaine, mepivacaine lacks vasodilator activity. So it doesn't cause vasodilation of the blood vessel, and it has an alternate selection, and the addition of epinephrine to the local anesthetic solution is not recommended. Okay, so it doesn't require addition of epinephrine like lidocaine to prolong the action. That is the main difference between mepivacaine and lidocaine. How is bupivacaine metabolized?
It is also metabolized.
It is also all are liver enzymes by the liver only in the enzymes. So same method of dealkalination, amide hydrolysis and conjugation, and the urinary excretion of bupivacaine and its alkalization products is more than 40%. How is ropivacaine metabolized? Okay, it is also metabolized by pipecholine xylidine, just like lidocaine by the hepatic cytochrome 450. So, Blancetta, please remember, most of them are by hepatic enzymes, and very false fraction is by treated unchanged in the urine, and it is highly bound to alpha-1 acid glycoprotein. That is the only difference between that. What is the toxicity ratio of a local anesthetic agent?
So it is the
Ratio of
concentration.
CNS to CVS.
CVS symptoms. Very good. It is the plasma level of local anesthetic needed to produce CVS effect divided by the plasma level needed to produce CNS effect. What are the values for lignocaine, bupivacaine, and levobupivacaine?
So for lignocaine it is 7. So for bupivacaine it is 2, sir.
3, levobupivacaine 5. Okay. So lignocaine 7, bupivacaine 3, levobupivacaine 5. Okay. What are the advantages of ropivacaine?
Sir, it is cardiotoxic and
Less lipophilic, so less likely to penetrate large myelinated fibers and reduce motor blockade. Second thing is, because of that, it is less central nervous system and cardiotoxicity. What are the new methods of prolong the duration of local anesthetic action?
Putting it through liposomal carriers.
Very good. Liposomal encapsulation, then biodegradable polymer microspheres, and site 1 sodium channel block, that is neosaxetone toxin. Okay. So these are all how these mechanisms are worked. What is lipid rescue for local anesthetic systemic toxicity?
Sir,
Injection of a lipid emulsion to act as a reservoir to bring out local anesthesia from the systemic circulation into the lipid reservoir.
Very good, excellent. So giving lipid emulsion 20%, immediately give IV bolus of 1.5 ml per kg over 1 minute. Then start an IV infusion at 15 ml per kg per hour. Then maximum of 2 repeat of 1.5 ml per kg IV boluses may be given at least 5 minutes apart if the patient has cardiovascular instability or is in cardiac arrest still, and increase the rate to 30 ml per kg per hour if hemodynamic stability is not restored after 5 minutes. Okay. And continue infusion until hemodynamic stability is restored up to the maximum dose. Do not exceed a maximum cumulative dose of 12 ml per kg. Okay. And based on lean body weight is the extremely obese patient. These are all the precautions that you have to take. What is this class of drug? Amide or ester?
amide group, sir.
Amide group. Are you using this?
Yes, sir.
Very good. Okay. So it's amide class of local anesthetic. What are the characteristics of the drug? Already we have seen 2 characteristics. It has less lipophilic attraction, so less penetrating of large myelinated motor fibers, and it has marketed as a S enantiomer which has less cardiotoxicity and neurotoxicity. What are the doses of ropivacaine? Is it only the spinal preparation which is available, or other preparations are also available?
Other
For nerve
preparations,
blocks,
0.2
we have
0.25.
0.2, 0.5 and 0.7.
0.75. Yes, we have 3 preparations. Very good. So for lumbar epidural, for cesarean section, what is the dose?
20 ml
Okay.
of
It is can be given 20 to 30 ml, 0.5, or 15 to 20 ml of 0.75 also. For thoracic epidural, 5 to 15 ml of 0.5 or 0.75. For major nerve blocks, you can go up to 35 to 50 ml of 0.5 or 10 to 40 ml of 0.75. And intrathecal block, you can use 2 to 4 ml of this particular 0.5 or 0.75 depending upon the level required and whether it is isobaric or hyperbaric. What are the various preparations are available? As you rightly said, 0.2, 0.5 and 0.75. These are the 3 preparations that are available apart from the ropivacaine heavy which is for spinal analgesia. This is another drug which is common after recently being introduced again. What is shown here?
sir,
Is it
1%
an amide or a ester drug?
ester local
It's an
anesthetic.
ester drug. Very good. It's an ester linked local anesthetic. What are its uses? Again, it can be commonly used as a topical ophthalmic for short procedures on the surface of the eye, nose, and ear, or also in spinal anesthesia. Okay. What is its pKa?
No idea,
It's
sir.
about 8.46 at room temperature. Okay. And what are the characteristics of this drug? First, many of you may not be using this. Its life solubility, tetracaine is very high. Thus, it is among the most potent of any local anesthetic. So, very, very long duration of action, more than bupivacaine also. And it's protein bound at about 75%, allowing a relative duration of up to 200 minutes. That is almost 3 hours and 20 minutes. How is it metabolized?
By plasma esterases.
Ester means it undergoes by plasma cholinesterase produced in the liver and to alcohol and para-aminobenzoic acid. What is the importance of this para-aminobenzoic acid?
It's an allergic compound.
Allergic compound. It can produce allergy. So dose not to exceed 1.5 to 3 milligram per kg. And how does cause allergic reaction? It is primarily due to HABA. In addition to that, there is also necessary to review drug label for addition of preservative, especially methyl paraben, which also metabolizes to HABA. Okay, these are the 2 reasons. The drug itself gets metabolized to para-aminobenzoic acid, and sometimes there may be a preservative methyl paraben also added, which also will contribute to the color. This is another recent drug which has been commonly used. What class of this drug?
Sir, ester link
This is
local
also
anesthetic.
ester link. Very good. What is the uses of this drug?
It is a
Spinal
rapid acting and short acting drugs.
It's a neuraxial anesthesia, caudal, epidural, lingual blocks. Due to short action, so tetracaine is the longest acting, chloroprocaine is the shortest acting. Okay, that is how you can remember easily. That is why they are given chloroquick also. Here the name itself gives you a clue, so that it is being used to evaluate the function of peripheral nerve and epidural catheters. And it is used in obstetric mainly to provide fast onset epidural anesthesia when urgent or emergent cesarean delivery is indicated. Okay. And ideal for short surgical procedures done as daycare because of faster recovery of both motor and sensory blockade. Patient will be fit for discharge much earlier. What are the preparation dosage of chloroprocaine? Any other preparations other than this? It is supplied as 1%, 2%, and 3% available. Okay, so here it is 1% what you see here, and it is a ampoule of 5 ml mainly for spinal. And it is 1% and preservative free also. And solutions are used for filtration epidural, and the dose maximum is 11 milligram per kg without adrenaline, 14 milligram per kg if it is mixed with epinephrine. And this intrathecal can give maximum 50 milligram for non-obstetric population. And 3% chloroprocaine, chloroprocaine 25 ml used for lumbar epidural, emergency cesarean. And a repeat dose can be given if you have a catheter in situ after every 45 minutes because of the short duration of action. And recovery following epidural block will be within 30 to 60 minutes. Now, having finished those, in addition to that, you have to remember levobupivacaine and the bupivacaine heavy and your regular lidocaine. All those things are not included because those drugs are all commonly used and you may be knowing all the answers. So I thought I will just include the newer agents that are not commonly seen by you. Okay, so refresh your knowledge on those commonly used drugs before going for your exam. And what is the structure of a sympathomimetic? So they are all monoamine neurotransmitter. Catecholamine is the basic structure. It is a monoamine neurotransmitter. It's an organic compound that has a catechol ring. What do you mean by the catechol ring? Which is a benzene ring with two hydroxyl side groups next to each other, the side chain amine. That is the catecholamine. So the catechol ring is nothing but a benzene ring with two hydroxyl groups. And if NH3, one amine is added to that, it becomes a catecholamine. So this is the basic benzene ring with two hydroxyl group. This is called the catechol ring. Okay. So hydroxyl group at C3 and C4 position of the benzene ring. Now to that you add one amine group NH2, then it becomes dopamine. So amine group added at C1 addition to hydroxyl at C3, C4 becomes dopamine. Now noradrenaline, you find another hydroxyl group is added here in addition to the amine. So another hydroxyl attached to the amine side chain becomes noradrenaline. Then you add one methyl group here to the amine and hydroxyl, then it becomes adrenaline. So this is the basic catechol nucleus to which gradually it becomes dopamine, noradrenaline, adrenaline, various steps that I've been going through the formation. So methyl group added to the amine side chain becomes the adrenaline. So this knowledge is important for you to understand how these syntheses are being done That will be asked in the examination, how it is the synthesis of catecholamines in the body. So, how are symptomatic drugs classified? Okay, naturally occurring catecholamines, that can be adrenaline or adrenaline and dopamine. Okay, then synthetic drugs, dobutamine, dopexamine, isoprenoline. They also have the basic structure of catecholamine. Okay, but they are all synthesized in the laboratory. And other inotropic agents which also have symptomatic activity are aminophylline, mildrinone, levosimendan, calcium, and even thyroxine hormone also has a symptomatic activity. And coming to the commonly used drug, adrenaline. What is the difference between these two preparations you are seeing here?
So one is bitartrate, one is acidic preparation. HC.
That is hydrochloride. Okay,
Yes, sir.
so there are two salts. One is adrenaline bitartrate and another is adrenaline hydrochloride. Is there any difference between the two?
Dosage will be.
No, that's what. Adrenaline bitartrate is synthetic, whereas adrenaline chloride is naturally occurring. Okay, that is the main difference between the two. What are the various uses of adrenaline in clinical practice?
So cardiac arrest, anaphylaxis,
Hmm.
bradycardia,
Bronchospasm.
bronchospasm,
Bronchospasm, bronchospasm. Okay.
along with local
So
anesthetic.
cardiac arrest 1 milligram every 2 to 3 minutes for adults and 10 microgram per kg for pediatric patients. Used in anaphylaxis, incremental doses of 100 mics IV, 0.3 to 0.5. So please remember the doses also, because the examiners may just not accept only saying cardiac arrest and anaphylaxis. But better to remember, they may ask you the dosage also. And it can be used as an inotrope in ICU, doses of 0.1 mics to 0.3 mics per kg per minute. And it can be nebulized to 1 milligram in 2 ml for acute asthma. And it can be added to LA drugs to prolong the action. These are the main actions that you have to remember. Then another common drug, all of you should be familiar with that, is what is NORAD? How is NORAD marketed?
Noradrenaline bitartrate.
Bitartrate. How much milligram per ml? How many ml ampoules?
So
It is 2 milligram per ml in 2 ml ampoules. Everything is clear. No?
yes, sir.
You can see the composition. Supposing ask you this sort of question comes, go through the composition, you can find the answer. So it is 2 milligram per ml and it is a 2 ml ampoule. Okay, and it's a bitartrate salt. So what class of drug is noradrenaline?
Inotropes.
Naturally occurring, endogenous catecholamine or naturally occurring catecholamine. So first thing we classified symptomatics as in naturally occurring, adrenaline, noradrenaline, and dopamine. So you must say whether it is endogenous or naturally occurring catecholamine or synthetic one. What is the dose, what route, and why? All of you should be familiar using this.
0.01 to 0.
0.1 to 1 microgram per kg per minute via central line. Why you want to give it by central line?
Since it is a vasoactive drug, it will lead to ischemia when we give it in the periphery.
Extravasation can lead to tissue necrosis if administered via peripheral vein. But if you are not able to succeed or if you don't have experience in putting a central vein, how will you administer it?
You can
Large
put it-
diameter vein, so as close to the heart as
but
possible.
prefer to take a cubital vein. It will be the largest vein in the available thing and infuse it through that. Okay. What is the mode of action?
It acts on alpha and beta receptors.
Alpha beta receptor, alpha more than beta. Okay.
Yes.
So this is the vasopressor and a weak inotrope, alpha more than beta. What are the indications for its use?
It is a first drug of choice in sepsis.
Septic shock.
Yes,
So
sir.
in
Septic shock.
hypotension refractory to fluid resuscitation, primarily in distributive shock such as septic shock, neurogenic shock, or post-bypass vasopresbyopia or drug is used for hypotension. What are the adverse effects of this drug?
So it causes
Reflex bradycardia.
reflex bradycardia increase in the
Hypertension,
lactate
reflex
levels.
bradycardia, hyperglycemia, increased afterload and beta effects if the dosage is over too much, causing increased myocardial work and peripheral ischemia. These are all the bad effects of this drug. Dopamine and dobutamine. Sometimes they can ask you to compare these two drugs. How do you compare these two drugs? What are all the points you can think of?
Dopamine is an endogenous catecholamine.
It is naturally occurring. Dobutamine is a
Dopamine is
synthetic.
synthetic.
Okay.
Dobutamine decreases the afterload, sir.
Okay.
Beta, the dopamine action.
Your audio is breaking and not okay. So source dopamine is natural catecholamine, dobutamine synthetic, and precursor is norepinephrine, also known as norepinephrine received in cardiac terminals. It does not release norepinephrine because it's synthetic. Mechanism: adrenergic plus dopaminergic receptors. It's a pure adrenergic. Dobutamine acts more on beta 1 more than beta 2 and alpha. So effect, it has an increased sustained effect, increased neutral, decrease, can decrease its action. And effect on the pulmonary capillary wedge pressure, it's not a favorable effect. It can reduce or optimize. Improves effect on renal blood flow, improves at low dose. It was original thinking that you give low dose dopamine, it improves, but this has now been not accepted. And dobutamine does not have any effect on the renal blood flow. Arrhythmias is more with dopamine, and it is equally more with dobutamine, but comparatively that safer. Inotropic action is less, is more consistent with dobutamine, and clinical utility is quite good. And, here it is slightly different in children. In shock, it is good, whereas it is not good in shock. Cardiac failure cases, it is good to use dobutamine rather than because of the decrease in the afterload, it will help in something much better. So how these drugs are marketed? Dobutamine is marketed as 250 milligram per 20 ml, and it is also available as a lyophilized powder form as well as be diluted. And it is available as 5 ml ampoules also, whereas dopamine is usually a liquid which has 200 milligram in 5 ml. Okay? So these are the preparations that are available that may be shown in the examination. And digoxin, one of the drugs which will be kept in the examination. And what are the indications for its use? Use of the following preparations of digoxin. This digoxin 500 microgram in 2 ml, or digoxin tablets, and which is 0.25 milligram oral tablet. These are the two preparations are available. What are the indications for these two preparations? When will you use digoxin by parenteral route? When will you use digoxin by oral route?
So for arrhythmia, like atrial fibrillation, cardiac failure, we can use digoxin.
There are two types of digoxin loading. One is called rapid digitalization and another is called slow digitalization. Okay, in those days we used to do that on all mitral stenosis patients. Previously used to receive digoxin as a routine to improve their myocardial contractility and cardiac output. So injection is for rapid digitalization, tablet is for slow digitalization. Why? What is slow digitalization? That is, when you give the tablet orally, it takes at least 48 hours for the effect to come on. Whereas by giving IV, you can achieve the effect within 6 hours. That is called the difference between rapid and slow digitalization. What is the mechanism of action of digoxin?
It is a
So it is a
cardiac
cardiac
inotrope, sir. It
glycoside.
acts on the sodium calcium channel, importer.
Potassium
So
ATP.
ATPase inhibitor.
Fantastic. So this is a acting on the sodium, potassium, calcium channel inhibitor. So improves the intracellular calcium level so that it will improve the inotropy or contraction of the cell. Okay. So digoxin acts on the sodium, potassium, ATPase pump, and that improves the intracellular calcium level, which increases the contractile force. That is one mechanism of action. Second, increases the vagal tone, decreases the AV conduction, decreases the rate. So by these two mechanisms, it is able to improve the cardiac output. One by suppressing or inhibiting the sodium potassium ATPase pump and improving the calcium level and increasing the contractility, and decreasing the rate by vagal stimulation. Okay. So these are the two mechanisms we have to remember. So what is isoprenylin?
It is a beta adrenergic.
It's a synthetic drug. First classification in this earlier slide I showed you is always say it is a non-selective beta adrenoreceptor agonist. It is isopropylamine analog of epinephrine. And it is a synthetic preparation. Okay.
Yes.
So this is the structure of, what is the structure you saw earlier? Methyl group is there, amine group is there, 3-hydroxyl. What is this?
Noradrenaline.
This is adrenaline.
Adrenaline. Yes. Sir.
Okay, and there is no methyl group here. Okay, so this is the norepinephrine, I mean isoprenylin. Okay, so that is how the whole thing is. What are the indications and contraindications for the use of isoprenylin?
It is used in the case of bradycardia.
Bradycardia, mainly to stimulate increase the heart rate. So used in the treatment of bradycardia to excess dose of beta blocker, heart blocker, rarely for asthma. Any other? It should be used in people with not be used in tachyarrhythmias or tachycardia or heart block causing by digitalis poisoning. Okay? Ventricular arrhythmias which require inotropic therapy or with angina. These are all the contraindications for that. Okay? So indications are bradycardia due to excess beta blocker or heart block. Contraindications are tachyarrhythmias and digitalis poisoning and ventricular arrhythmias. What is the half-life of isoprenylin? It's about 2 minutes, very, very short acting. So what is the dose? Because these drugs are all not commonly used, I don't expect you to often remember. Bolus intravenous injection, dilute 1 ml in 9 ml of sodium chloride and or 5% dextrose, and use 0.2 milligram to 0.6 milligram. That is 1 ml to 3 ml of diluted solution, and 0.1 to 0.2 or 5 ml to 10 ml of diluted solution can be used to increase the heart rate depending upon the requirement. What is dopexamine? Another synthetic analog of dopamine. Okay, so dobutamine, dopexamine are synthetic drugs, isoprenylin. These are the three synthetic drugs which I told you in the first series, first slide of classification. So it is presented as 50 milligram in 5 ml ampules. Its mechanism of action, all of them should act on alpha and beta. So, but here it acts on beta 2 and dopamine 1 receptors, and no effect on alpha receptors. That is the peculiarity of dopexamine. So it is mainly to improve the beta 2 receptor activity. So uses in improve cardiac output and mesenteric perfusion. Dose of the drug is 0.5 to 6 mic per kg per minute. Half-life is about 7 minutes. Potentially hazardous interactions with other drugs are antidepressants, risk of hypertensive crisis with MOS and hemoglobin, and beta blockers, risk of severe hypertension, and symptomatics, effects of adrenaline or adrenaline possibly enhanced. So these are all the drugs where we have to carefully use this drug. Another drug which commonly you are using nowadays, what is phenylephrine?
Potent alpha.
Alpha agonist.
It is an alpha agonist. Very good. Okay. Right. So hydrochloride form of phenylephrine, the direct acting sympathomimetic amine chemically related to adrenaline and ephedrine, which both have potent vasoconstrictor property. Okay. And how does it help in treating hypotension?
So it acts on alpha 1 receptor and causes
Acts on
peripheral
the-
vasoconstriction, increases SVR.
Acts on the arteries or veins?
Arteries.
Both arteries and veins. Okay, it helps in raising mean arterial pressure by inducing vasoconstriction in both veins and arteries, and enhancing cardiac preload without exerting significant effect on the cardiac myocytes. Okay, just by improving the cardiac preload, it helps. What are the various presentations of phenylephrine? How many milligram per ml or
1 milligram per ml ampules.
It was initially marketed as 10 milligram per ml. Okay. Then it has become available as 50 milligram in 5 ml, and 100 milligram in 10 ml, milligram per ml vials also. And now we have 100 microgram, that is 1 milligram diluted to 10 ml preloaded syringes are also available, which is not available here, but Western countries it's available. So now normally this is cumbersome to dilute first 10 milligram to 10 ml, then take 1 cc of that and then again dilute it to 10 ml. That is how we use it for getting a dilution of 100 mics per ml. Isn't it? Are you using like that?
Yes, sir.
So available as 1 milligram in 10 ml or a preloaded syringe of preloaded syringe or 10 milligram 1/10 ml ampules. What are the over-the-counter uses of phenylephrine?
It's used as an anti-congestive agent.
Nasal decongestant.
sprays.
And also ophthalmic formulations for precipitate mydriasis and uncomplicated nasal congestion. Topical is a hemorrhoid medication, so additional to cause decreased bleeding. What are the routes of administration of phenylephrine?
Intranasal,
Intravenous,
intravenous.
we normally give intravenous as anesthesiologist for treating hypotension, but it can be also given intranasal, ophthalmic, and rectal, and topical. Okay. What is the dose of phenylephrine?
50 to 100 mics IV boluses.
Bolus followed by, supposing you want to give it as an infusion, totally 0.1 to 1.5 mg per kg per minute. Okay, that can be given initially as an IV bolus and then maintained also as an infusion. Okay, ephedrine is another common drug that we are using. What is ephedrine?
It is an indirect sympathomimetic.
Direct and indirect mechanism of action. It is not the sympathomimetic amine. What is the mechanism of action? It has
Increases the
both
release.
direct and indirect sympathomimetic activity. What do you understand by that direct and indirect sympathomimetic effect?
Direct is it has the actions of the receptor. Indirect is releases norepinephrine and epinephrine from vesicles.
Receptor, very good. So direct is on the cardiac musculature. So it acts directly both on the alpha and beta receptors, and also indirectly by inhibiting the neuronal norepinephrine take and dispersing more norepinephrine from storage vesicles. That is called the indirect effect. What is tachyphylaxis and how does it happen with ephedrine?
Sir,
Tachyphylaxis is desensitization of the receptor due to repeated doses of ephedrine.
Very good.
This can be reversed only by when the new receptor is synthesized.
Okay. And so what is the mechanism? How does it happen? Because the storage of norepinephrine is exhausted. Okay, that is why it happens. Decreasing response to repeated doses is known as tachyphylaxis. Very simple way to remember is decreasing response to repeated doses is known as tachyphylaxis. And here, if you see this picture, the cytoplasmic pool of norepinephrine is exhausted by the time repeatedly when you give that, and it causes the release of norepinephrine. The norepinephrine storage here becomes exhausted. So no more norepinephrine will be released, and that is the reason how the tachyphylaxis occurs. Okay, that is the ephedrine mechanism, normal action, and as well as tachyphylaxis well explained in this picture. What herbal medicines contain ephedrine? Why they are banned? Any idea? The price question. Anybody wants to get a university rank, they have to answer this. Okay. Ephedrine is an active ingredient in Nagaswamy, a popular herbal medication. Increased risk of stroke, myocardial infarction, and sudden death are the reasons for the drug being banned. Is ephedrine safe for fetus when used in pregnancy? We are commonly
causes
using it
fetal
in all
acidosis.
patients who undergo cesarean section and spinal. If that's a fall immediately, we give 6 to 12 milligrams of ephedrine as the first choice, isn't it?
Yes, sir. It is safe, but it causes fetal acidosis. It crosses placenta.
It can crosses the placenta and affect the fetus by increasing fetal heart rate due to its beta adrenergic stimulation effect, leading to fetal acidosis with high doses. So if you keep on repeating more than 30 milligrams to control or improve the hypotension, then it can result in fetal acidosis. So try to avoid too much of ephedrine. If it is not responding, switch over to some other type of vasopressor instead of giving more and more ephedrine. Okay? What salts of ephedrine are available and what is the difference between them? Commonly you see ephedrine hydrochloride, isn't it? Most of the salts will be hydrochloride salts. You know why?
To make it stable.
Make it water soluble. That is the preparation which is easily water soluble. Okay. So ephedrine is available as hydrochloride and sulfate salts. And HCl preparations have higher ephedrine than sulfate preparations. Okay. So if you get a ephedrine sulfate in your supply, that will contain less ephedrine compared to ephedrine hydrochloride preparation. Vasopressin is another exam drug which normally not used frequently by the students. So it is available in units per ml. What is vasopressin?
It is a antidiuretic, synthetic
It is a
antidiuretic.
hormone.
Yes.
It is a hormone. Vasopressin is antidiuretic hormone, important endogenous hormone which is responsible for regulating plasma osmolality and volume. Okay. What are the actions of this drug?
So it increases the SVR and it acts on the renal vasopressin receptor and causes increased water and sodium
How many
reabsorption.
vasopressin receptors are there?
2, sir.
3. Okay. Yes.
Okay, sir.
So I'll tell you that acts on the neurotransmitter in the brain to control circadian rhythm, It also has a role in thermoregulation. It also has a role in adrenocorticotropic hormone release, ACTH release. And its therapeutic effects, this is the normal physiological effect as a neurotransmitter, as a thermoregulatory and ACTH release. Therapeutic effects of the drug, the therapeutic are in critical care, the management of cranial diabetes insipidus, bleeding abnormalities, esophageal variceal hemorrhage, asystolic cardiac arrest, and septic shock. And these are all the conditions where it can be used. What is the physiology of vasopressin? Where is it synthesized? Where it is stored? Where it is released?
It is synthesized in the hypothalamus and stored in posterior pituitary.
Posterior pituitary. Okay, it's a nonopeptide synthesized as a prohormone in the magnocellular neuron cell bodies of the paraventricular and supraoptic nucleus of posterior hypothalamus. This is the exact location of their synthesis. It is bound to carrier protein called neurohypophysin and transported along the supraoptic hypophyseal tract to the axonal terminal of the magnocellular neurons located in the posterior pituitary. So as you said, a small way of remembering is it is secreted in the hypothalamus, even if you don't remember the paraventricular supraoptic nuclei, and then transported and stored in posterior pituitary to be released whenever there is a need. And a plasma concentration is less than 400 picograms per ml. Half-life is 10 to 35 minutes. Metabolized by vasopressinases found in the liver and kidney. Okay. And it acts on V1, that is vasopressin 1, 2, 3 receptors and oxytocin type of receptors. So all the four are activated. What is the role of vasopressin in ACLS, advanced cardiac life support?
It is the second.
What are the modifications of the guidelines? So vasopressor functions as a vasoconstrictor when it is used at supraphysiological doses as 40 units and helps in transferring the blood to central compartment without the adverse effects of epinephrine. That is, when you use large doses of epinephrine, after the heart starts beating, when return of spontaneous circulation is regained, the heart goes into severe tachycardia because of the effect of epinephrine and also severe systemic vascular resistance. So all the ill effect will not be there if you use vasopressin. That is the it is being recommended in cases where this problem happens. So another ICU drug is not commonly used is adenosine. So what is adenosine?
Nucleoside.
It's a nucleoside, very good. It's a purine, naturally occurring purine nucleoside. So adenosine is one of the 4 nucleoside building blocks to build DNA, RNA, which are essential for all life. What is the difference between a nucleoside and a nucleotide?
Nucleotide is the combination of nucleoside and base.
More elaborate. So this is the nucleoside, which is a base plus sugar. Okay, if you add a phosphate group, it will become nucleotide. Okay, so base plus sugar is nucleoside. With phosphate, it is nucleotide. So what is the therapeutic use of adenosine?
So supraventricular
SPT.
tachycardia.
Supraventricular tachycardia in the treatment of SPT and the nuclear stress test as adjunct to thallium. What is the mechanism of action and side effects?
So it blocks the adenosine receptor.
Blocks or activates? Increases potassium efflux, decreases calcium influx, thereby hyperpolarizes cardiac cells. Okay, that is how the stimulation is reduced. So clinical applications are paroxysmal supraventricular tachycardia. You give rapid IV injection. Half-life is only 2 to 10 seconds, and it will cause flushing, chest pain, and dyspnea. And it will aggravate bronchial asthma, or it will aggravate AV conduction block also. So it is contraindicated in these two conditions. So these are the mechanisms. It causes increased potassium efflux and inhibits the calcium influx. So it becomes more, the potassium is retained, calcium is prevented from coming in, hyperpolarization occurs, and the tachycardia is immediately controlled. What is the half-life and how it is metabolized? So half-life I have shown here. So half-life is less than 10 seconds, rapidly deaminated in plasma and taken up by RBCs. That is the mechanism of the removal of this. So drug is esmolol. It is commonly used. What is esmolol?
Ultra short acting beta blocker.
Ultra short acting cardioselective beta blocker. What are the uses?
In accelerated hypertension, it can be given as an infusion.
Blunting and hemodynamic response to laryngoscopy and intubation, episodic atrial fibrillation of cluster to control ventricular rate, to reduce heart rate BP during and after cardiac surgery, especially beating heart CABG, and to terminate supraventricular tachycardia. Why it is named esmolol? What is its relevance to its metabolism?
Metabolized by plasma esterases, sir.
Very good. So why it is called VSM esmolol? Because structural reflectase, it is a ester methyl. Okay, it is a ester methyl compound. So from that it is VSM has been taken, and these are rapidly metabolized hydrolysis ester linkage by the cytosol red blood cells, not by plasma cholinesterases or red cell membrane acetylcholinestrases. The dose
0.5 mg
0.15 mics per kg per minute.
0.15 mics per kg, 0.milligram.
0.5 milligram.
Zero loading dose 0.5 milligram per kg, followed by 0.05 to 0.2 milligram per kg with infusion, not microgram, larger doses. That's why you can see whenever a drug is available milligrams, mostly it will be larger doses. Another drug not very commonly used, amiodarone. What is amiodarone?
Antiarrhythmic.
Antiarrhythmic agent,
Potassium
benzofuran derivative. Chemically, it is a benzofuran derivative. What is the mechanism of action?
Potassium channel blockers.
It is a blocks the potassium channel and also has a mild blockage of sodium and calcium channels and beta receptors, so that it depresses the SA node, prolongs the action potential duration, prolongs the effective refractory period and repolarization. Okay. So main action is by potassium channel blocker, mild action by these two. What are the uses of this drug?
So it is used as an anti-arrhythmic.
Chemical
Treatment of
cardiovascular.
what type of arrhythmia you should say? Anti-arrhythmic is a general term. So you must use SVT, ventricular tachycardia, and WPW syndrome. These are the common indications. What is the dose?
300 milligram bolus followed by over 10 minutes, followed by
For arrhythmia, it is 150 milligram bolus, followed by 1 milligram per hour for first 6 hours and 0.5 milligram for next 18 hours.
Okay. So loading dose 5 milligram per kg over 1 hour, followed by 15 milligram per kg for 24 hours. Okay. So that is how it is given. What are the side effects?
hypotension,
And
hypothyroidism,
Hyper, long-term use. Okay. The thyroid abnormality, both hyper and hypo, photosensitivity, peripheral neuropathy, lung fibrosis. These are all long-term uses, and liver damage, cardiac depression, corneal microdeposits. Okay. So these are all the way you can remember. T, PP, LLCC, and nitroglycerin or glyceryl trinitrate. What is the mechanism of action?
venodilator.
It's a more of a
Increased
venodilator.
production
So
of
it
nitric
causes release of nitric oxide, activation of coronary soluble guanylate cyclase, increased coronary cyclic GMP level, and plasma level. What is this BK? Any idea? Plasma level BK channel activation. Anyone guess what is the expansion of this BK?
some kinase.
It's called big potassium channel, PK. BK means big potassium channel. It causes membrane hyperpolarization, decreased cardiac calcium influx, decrease in cytoplasmic calcium, coronary relaxation. Okay, simulation of sarcoplasmic reticulum to activate the calcium ATPase pump, enhance sarcoplasmic reticulation, removal of calcium from the cytoplasm. So reflected as decreased sarcoplasmic calcium release. That also causes a decrease in cytoplasmic calcium, smooth muscle relaxation. So this is the mechanism how it improves the coronary circulation. What are the effects on the CNS? CBS.
So it causes hypotension and
Mainly a
reflex diabetes.
venodilator, causes reduction in preload, decreases wall tension and oxygen demand, increases coronary blood flow. What is the cause of tolerance to nitrates?
Decrease in the increased down regulation of receptors.
Due to depletion of sulfhydryl group within the vascular smooth muscles. Okay? That is the chemical mechanism, depletion of sulfhydryl group within the vascular smooth muscles. How can the tolerance be prevented?
We have to stop the drug for 2 days in between.
2 hours of drug-free period and infusion of acetylcysteine. Okay, just like where did we use acetylcysteine earlier?
Paracetamol.
Paracetamol toxicity. Okay, there also sulfhydryl group and glutathione will be provided. So acetylcysteine can provide these two substrates for the activity of these drugs. Okay, so remember acetylcysteine. Right. Dexamethasone, the next relaxer.
So depolarizing.
How are drugs causing neuromuscular blockade classified?
So depolarizing and non-depolarizing muscle relaxation.
This is the common way everybody should usually answer, but the activity is those which prevent acetylcholine synthesis. Example is hemicolonium. Those which prevent acetylcholine release, like magnesium, aminoglycoside, botulinum toxin, they also cause neuromuscular blockade. Okay?
Yes.
And depletion of acetylcholine stores, which happens in tetanus injection or tetanus disease, and block of acetylcholine receptor by neuromuscular blocking drugs, that only is classified as depolarizing and non-depolarizing. Okay, so
Yes.
even though this is the common answer every student will give, there are other mechanisms by which neuromuscular blockade can still happen. That is why magnesium is used even preventing eclampsia, isn't it? As a prophylactic measure to prevent seizure activity, you are giving. So these are all the methods of blockade of neuromuscular activity. What are the side effects of succinylcholine?
So myalgia, hyperkalemia.
You have to remember these 8 changes: myalgia, cardiac arrhythmia, hyperkalemia, increase in IOP, increase in intragastric pressure, anaphylaxis, cholinapnea, and malignant hyperthermia. So the magic number is 8. You have to remember all the 8 side effects. What are the contraindications for use of succinylcholine?
History of malignant hyperthermia, potassium value more than 5.5 milliequivalents per liter.
Clinical conditions?
Chronic
Neuromuscular disorders.
What is very common thing you are missing?
Pediatric less than 1 year.
Burns. Don't forget that. Hyperkalemia states like CKD, severe muscle trauma, history of malignant hyperthermia or cholinapnea in the family, burns, spinal cord injuries with paralysis of long duration. Okay, so all these cases you have to avoid. What is shown here and how does its structure help the drug? So it's a aminosteroid non-depolarizing muscle relaxant. Okay. What is the other group of non-depolarizing muscle
Benzyl isoquinolinums.
Benzyl isoquinoline. So it contains an androstane skeleton, which like acetylcholine moieties are introduced at airing and dearing. So it does not cause systemic release. They tend not to cause systemic release. Most dependent on organ function for the excretion and undergo de-acylation in the liver, but the metabolic possesses 20 times less neuromuscular blocking properties. Can you compare rocuronium with vicronium? Both are aminosteroid.
Both are intermediate duration. So, but rocuronium, when we give it in higher doses,
Rocuronium is 6 to 8 times less potent than vicronium, first of all, potency wise. Okay.
sir.
And it is more lipophilic than vicronium. So most of the drug is taken up by liver and eliminated via bile. And rocuronium has no direct sympathomimetic effect, but in high doses it has a mild vagolytic property, which means it will cause a mild tachycardia. Whereas vicronium causes sinus bradycardia. Vicronium is marketed as a powder to be reconstituted, whereas rocuronium is available as a liquid. Okay, so this is Neovec, all of you be familiar with. We have reconstituted. What is the dose of rocuronium?
For modified RSI, it's 1.2 milligram per kg. Otherwise, 0.5 to 0.6 milligram per kg.
Excellent. Okay. So that is the rapid sequence 1 to 1.2, maintenance 1.2. What is the dose of sugammadex decided based on the intensity of rocuronium blocking?
For profound block, up to 16 milligram per kg sugammadex can be given. For routine reversal, minimum 2 milligram per kg dose can be given.
In between, there is no
For
dose.
moderate block 4 mg.
Moderate 4 to 8 milligram
So
per
it
kg.
is based on the terrain of 4. With that only we decide. So there are no twitches to terrain of 4, which indicates a very intense block, 16 milligram per kg. If there is no TOF but 1 or 2 post-tetanic responses, 4 milligram per kg. A 4 twitch, that is all the 4 twitches are present. The patient has started breathing spontaneously, then 2 milligram per kg is. This is the common dosage schedule that is asked. So 2, 4, 16, remember those values. This is another common drug which we now use. What is shown here?
Tranexamic acid vials.
It's a synthetic
It's an
lysine
acid
analog. It inhibits fibrinolysis, promotes clot stability, and may reduce inflammation. What are the indications for its use?
So to decrease bleeding in trauma,
Decrease bleeding.
obstetrics,
Administered to medical, elective, and emergency surgical patients can reduce bleeding and transfusion requirements. What is the mechanism of action?
it goes and binds to the plasminogen activating inhibitor and inhibits fibrinolysis.
So it is a reversible competitive inhibitor of the lysine receptor found in plasminogen. Okay? And binds the receptor, prevents plasmin, which is will get activated only if lysine is bound to that from binding and ultimately stabilizing factor max. So if you see this picture, this tissue plasminogen activator, plasminogen are this is the binding site, and fibrin has got these two receptors to receive them. So once all these three bind together, that is tissue plasminogen activator, plasmin plus fibrin, it causes fibrin degradation. What your tranexamic acid does is it goes and occupies this site in the plasminogen so that it doesn't allow the fibrin to get attached to this complex of tissue plasmin activator and plasminogen, so that fibrin is not broken down, so no fibrin degradation occurs and the fibrin clot stays strong and prevents further bleeding. What is shown here?
Thromboelastogram.
What is the influence of thromboelastogram in relation to this?
Fibrinolysis.
So this is a trend showing fibrinolysis. What are the contraindications for use of tranexamic acid? Known allergy, intracranial bleeding, known defective color vision, history of venous or arterial thromboembolism. Okay, all these things are the. Then cisatracurium and atracurium, commonly used drug. How many stereoisomers are there in atracurium and why?
10 stereoisomers.
10 stereoisomers and 4 chiral molecule. What is Hoffman degradation and what are the metabolic pathways of atracurium?
Hoffman degradation is
Non-enzymatic degradation.
Non-enzymatic, very good.
Spontaneous
Spontaneous
degradation.
degradation, the variations in body pH and temperature is called Hoffman degradation. Metabolic products are donidalin and quaternary monoacrylate. What is the other route of elimination and what are the metabolites?
metabolized by non-specific esterases, hydrolysis.
Ester hydrolysis, and that also leads into laudanolin, but quaternary alcohol and quaternary acids. Between cis atracurium and with atracurium, which has faster onset of action and why? What is the dose you give for atracurium has a faster onset of action because of higher dose, 0.5 milligram per kg required, whereas you give only 0.15 milligram for cis atracurium, isn't it?
Yes.
So that is the reason why faster acting, but cis atracurium is a little longer acting. Anticholinesterase. Classify the types of anticholinesterases. Okay.
Short acting.
Competitive antagonist is hydrophonium. Those which form carbamylated enzyme complex, neostigmine and pyridostigmine. Irreversible inactivation of acetylcholinesterase is organophosphorus compounds. Okay. This is the drug which you are using day in and day out. What are the types of acetylcholine receptors? Why they were named like that and what category they belong to?
So presynaptic, mature and immature acetylcholine receptors.
Acetylcholine receptor.
Nicotinic and
Nicotinic
Nicotinic and muscarinic.
Nicotinic.
Okay. They can be called nicotinic and muscarinic. Why they were called like that? What is the reason?
One bind that muscarine and one the other
the ligand
bind nicotine.
that was found there. Just like the mu, kappa and delta, where I said the ligand gave the name. Here the nicotine found to activate these receptors and muscarine, which is a poison from a toad, which is supposed to the ligand which were first used to bind with them, nicotine and muscarine, which is also known as mushroom poison. Okay. Nicotinic is a ligand-gated ion channel, whereas muscarinic is a G protein coupled receptor. These are all the differences between that. And you can see this picture. Nicotinic receptors, it's like just like your acetylcholine receptors at the neuromuscular junction, where they activates and they allow the entry of sodium and calcium. Whereas the G protein coupled receptors, they are also called serpentine or 7-pass membrane receptors. They go through this G protein stimulation and all those things. What are the uses of anticholinesterases?
Reversal of
Neuromuscular blockade, commonly you are using. Very good. Then
to differentiate between myasthenic crisis and cholinergic crisis.
Treatment of myasthenia gravis.
Treatment of myasthenia, very, very important. Okay, so this is some two important things that you have to remember. Then commonly used antiemetics, which we are using, that also will be kept. What is vomiting? What is the definition of vomiting?
It is a non-purposeful.
Non-voluntary.
So retching followed by expulsion of gastric contents is called vomiting. Okay. Name the different input to vomiting center and receptors and their location. What are all the afferent signals which can activate the vomiting center?
Serotogenic
Huh? So there are so many things: anxiety, raised intracranial pressure, gastric stasis, radiation, colitis, chemotherapy, drugs, hypercalcemia, vestibular. So the input are cerebral cortex input, peripheral input, chemoreceptor triggers on stimulation, vestibular input, all leading to the stimulation of vomiting center. How does dexamethasone help in vomiting, control of vomiting, which we are nowadays using regularly in the prevent post of vomiting? Lot of mechanism. Glucocorticoids may activate the following mechanism: anti-inflammatory effect, direct central action on the solitary tract nucleus, the interaction with neurotransmitters serotonin and receptor protein tachykinins NK1 and NK2 and alpha adrenaline, etc., and maintaining the normal physiological functions of organs and systems, and regulation of hypothalamic pituitary adrenal axis, reducing pain and concomitant use of opioids, which in turn reduce opioid-related nausea and vomiting. So these are all the various mechanisms. Earlier it was said how dexamethasone acts, nobody knew, but now these are all the proposed mechanisms. They are not exactly the final word, but there are different mechanisms proposed as the mode of operandi of dexamethasone. How metoclopramide helps in vomiting?
Dopamine.
kinetics, sir.
Dopamine receptors. Blocks the central dopamine receptors in the chemoreceptor trigger zone. Also acts on the peripheral dopamine receptors to cause prokinetic effect on the stomach. Augments peripheral cholinergic receptors and blocks 5-hydroxy return receptors also. So 4 mechanisms are there for the action of metoclopramide. This is one of the new drugs which are likely to come into the use recently. What is the drug shown here?
Remimazole.
It's a benzodiazepine group drug, remimazole. How does it differ from midazolam?
So it is metabolized by, it has an ester group like remifentanil.
Ester hydrolysis.
Okay, so it's rapidly converted to inactive by tissue esterases, resulting in ultra short action and offset. Midazolam is metabolized by hepatic CYP450 and glucuronide conjugation. And it is marketed as a powder which has to be reconstituted, whereas your midazolam, all of you know, is a liquid. And midazolam is marketed as clear colorless solution for IV use and in syrup form also, whereas this is not available for oral use. What are the advantages of remimazole?
It is very short acting, so it can be used in
Completely reversed by the benzodiazepine antagonist 2 months earlier. Okay, if you want to reverse the action after giving a larger dose, you can immediately reverse it. Has minimal cardiac or respiratory depression, no cumulative effect over time, no burning sensation upon injecting into IV line, and even paramedical person can administer safely. What are the indications and dose of remimazole? Used for general anesthesia and procedural sedation. Dosage for general anesthesia is just 6 to 12 milligram per kg per hour, followed by maintenance infusion of 1 milligram per kg per hour. And for procedural sedation, initial dose is 5 milligram over 2 minutes, supplemented with 2.5 milligram every 2 minutes when required. This is another common drug. Midazolam is a benzodiazepine group of drugs. What are the actions and how they are caused?
Sir, amnesia and anxiolysis.
How is it caused? Where does it act? It is hypnotic and anxiolytic effects caused by action on GABA A and GABA B receptors. How is it presented? Already shown in the earlier
Liquid.
slide. It is available as liquid for injection, clear colorless solution. And what is the pH?
pH 4,
3.5 acidic.
3.
Okay. How
Yes,
is the peculiarity of the structure of midazolam?
It also exhibits tautomerism.
Tautomerism. Its structure is dependent on surrounding pH. At pH 3.5, it is a diazepine ring structure is open, making it an ionized molecule in water soluble. At a pH of more than 4, the ring structure closes, making it unionized and lipid soluble, so that at physiological pH, 89% is unionized, realizing in faster onset of action. This is the difference between the two structurally. And this property is called tautomerism or dynamic isomerism. The other name for that is dynamic isomerism. How does this drug differ from the older diazepam?
Yes.
How does it differ from midazolam? This was the precursor or the predecessor to midazolam. During our
Longer.
PG days, this was a common drug. So this is midazolam is more rapid onset, greater amnesia, and 2 to 3 times as potent, twice affinity for benzodiazepine receptor, greater decrease in blood pressure and heart rate with diazepam, increase with systemic vascular resistance, less midazolam has less post-procedural sedation compared to diazepam is longer acting. So how does diazepam overdose treated? What is the antidote for it?
Flumazenil.
Flumazenil, what is the
milligram.
dose? Antidose is 0.1 milligram bolus up to 0.3 to 0.6 IV depending on the consumption dose of diazepam. Okay? And so flumazenil available at 0.1 milligram per ml in 5 ml vials. So it is not on the body weight basis, it's just 0.1 milligram bolus followed by 0.3 to 0.6 IV. What are the adverse reactions of flumazenil? It can reverse the seizure and can cause seizure because it decreases the seizure threshold also, which diazepam has enhanced. So patient can throw a fit after flumazenil. They're known as epileptic patient. And last of this drug is phenytoin. It is used sometimes in your ICU practice also. What are the uses of phenytoin?
So it is used as an anti-arrhythmic and anti-epileptic.
Anti-arrhythmic and treatment of grand mal seizures, trigeminal neuralgia, treatment of ventricular arrhythmia caused by tricyclic overdose. What is the mechanism of action?
Sodium channel blocker.
It is a sodium channel blocker. Okay, so this is the mechanism how it is inactivated. They reduce calcium entry also into neurons, thereby blocking transmitter release and enhance actions of GABA. Under what class of antiarrhythmic drugs phenytoin is classified?
Class 1B.
1B, sir.
Class 1B, correct, good. Mannitol. This is another drug you may be using. What is mannitol?
It is an osmotic diuretic.
It's an osmotic diuretic. Why is it used?
To decrease the intracranial pressure.
To reduce ICP during neurosurgical procedure. Very good.
To
Then
decrease IOP during ophthalmic
IOP during
procedures.
ophthalmic. Excellent. Then
To cause diuresis as a
renal
renal.
function in jaundice patient. That is especially obstructive jaundice. Then promote diuresis in donor during renal transplant. Promote renal function during aortic surgery after promptly release. What is the half-life of mannitol? About 100 minutes.
4 hours.
And Lasix, furosemide. What is the mode of action of Lasix?
It is a loop diuretic. Acts at
Loop
sodium
diuretic.
potassium chloride.
It acts on the inhibits the reabsorption of sodium chloride in the thick ascending loop of MV. and to some extent in the early part of distal convoluted behavior also. Action impairs countercurrent multiplier system to reduce medullary hypertonicity, causing reduced free absorption of water. Okay. Why it is called acid?
Lasts for 6 hours.
The action lasts for 6 hours. Very good. Okay. Acetylcysteine. What is shown here and what are its uses?
So in paracetamol poisoning, as protection in liver transplant or any, and as a mucolytic also.
The natural sulfur containing compound that is produced in living organisms from amino acid cysteine. Okay? And intracellular synthesis of a chemical called glutathione. It is a powerful antioxidant. It has a mucolytic action on bronchial mucus secretion. It is used as an antidote for paracetamol poisoning and also to supply the sulfur radical for NTG tolerance. And how can help paracetamol overdose? This is of course already
replenishes
we
the
have shown
glutathione
that.
stores.
And the NAC also has all these actions to improve the antioxidant properties. How it is being done? How much is the dose for treating paracetamol poisoning?
So it is 150 milligram per kg loading.
IV over 10 minutes, followed by 50 milligram over 4 hours and 100 milligram over 16 hours. Side effects: nausea, vomiting, urticaria, fever, and bronchospasm. What is the purpose of IV fluid administration, which are also coming under drug category?
To prevent,
Maintain
maintain
tissue
homeostasis.
Maintain
perfusion,
homeostasis.
electrolyte concentration in normal. What is the composition of various IV fluids commonly used? That may be asked, so you must be prepared for all that. So the common IV fluids we use are ringer lactate, normal saline, plasma light, half normal saline, TNS, and dextrose in water, 5% albumin. So these are all the various IV fluids. So try to go through all the composition of various ions in that. Plus the osmolality is very, very important. So we must try to use solutions which are almost isoosmotic with the plasma. That is the way, the correct way to use that. And what does osmolality and tonicity mean? Are they same or different? So osmolality is a measure of osmotic pressure of a given solution, whatever be the pressure exerted by that solution. Whereas tonicity is a measure of the osmotic pressure gradient between two solutions separated by a permeable membrane. Okay? So you should not use isoosmolality with isotonicity interchangeably. Okay? So tonicity is always a comparison between two solutions separated by a permeable. So this is the sodium chloride and examples of that. So how are IV fluids classified?
Sir, isotonic, hypotonic, and hypertonic.
Based on osmolality can classify. Then classify based on the contents, crystalloids or colloids. Okay. Based on the osmolality, can be hyperosmolar, isoosmolar, or hypoosmolar. And how much of fluid will be retained in the intravascular compartment? 1 liter of 0.9% sodium chloride and 5% dextrose are infused.
0.9% NS is 20 to 30%.
So you give 1 liter, that is 1000 ml to a
Yeah.
patient of normal saline, and another
Yes.
patient 1000 ml of 5% dextrose. How much milliliters of this fluid will be retained in the intravascular compartment? Is the
250 to
calculation
300 ml.
roughly. Okay. So NS is isotonic, so it will be distributed in extracellular compartment. Intravascular compartment is 25% and extra of the ECF. Okay. So 250 ml will be retained in intravascular compartment. Whereas when 1000 ml of 5% dextrose is given, dextrose will be metabolized, leaving only 1000 ml of water, which is hypotonic. So since intracellular compartment has 2/3 water and extracellular 1/3 water, 333 ml will remain extracellular, of which 25% will be only 84 ml will remain in intracellular compartment. So that is the reason why in replacement you should not give dextrose as a replacement for retaining the volume. It should always be either interlactate or non-interlactate. Okay. So that completes rapid discussion of the IV fluids, drugs, and other things. So already we have touched 8 o'clock. Don't think we can go ahead and do the machines and equipments. Or shall I rapidly go through the slides of equipments other than machines? Because machines we recently saw a few equipments like endotracheal tubes and other things. Kamachi, what is your opinion? You have the time to go ahead.
So can we have one more complete essentials, because that's a very important thing. So we can cover the defibrillator and resuscitation part also.
Okay.
We have 1 more week's time.
Yeah, if the examining students are willing to attend 1 more class, I don't mind. In fact, we can cover all the important things better. We will try to avoid repetition of the machine discussion, because most of the machine questions we have already covered. So we will go through with the equipments like endotracheal tube, laryngoscope, video laryngoscope, and LMA varieties, and defibrillator, and other few things.
Yes, sir.
Okay, sir.
Okay.
Yes, sir.
Right.
But sir, can we sign off today's class, sir?
Yeah, I think so.
Thank you,
Thank you
sir.
very much.
Thank you, sir.
Thank you.
Yes, sir.
Thank you, sir.